Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizing committee for the invitation and for the outstanding hospitality of colleagues from Bahrain as well. Actually, Dr. Musa, I was asked to present non-left main dissection. So this is non-left main dissection coronary artery problem. I don't have any disclosure, but actually it's worth to mention that there's different approaches to complication. And as you can see from the talk today, that there is very variability from one operator to another. And this is, very well known because there's no evidence complication can happen. And the most important thing actually is just to make the patient safe and to get him alive from the table. Also, there was one question today about stenting left main, whether to stent or not to stent. And again, there is a lot of variability. Actually, I was having the courage now to leave a lot of dissection with the air of DCBs, LAD, proximal LAD. We know that angioplasty-induced dissection. So now we have the courage more and more to leave dissection. And actually, this case will just demonstrate one of these themes. So I'll go to the case. This is a 66-year-old gentleman who has multiple comorbids, CKD, liver cirrhosis. He had history of BCI to the LAD with drug-coated balloon before. And he was having also subtotal heavily calcified RCA that was planned for medical treatment. A few years later, the patient presented again with class 2 to 3 angina despite optimal medical therapy. So this is his angio, and as we can see, there is some moderate stenosis in the circumflex, heavily calcified artery. The LAD also from angiography seems heavily calcified. This is the cranial view showing the same. There's also kind of mild to moderate stenosis in the proximal LAD. And this is the area where the DCB was used and seems overall acceptable. And as we can see from these images also, there's some collaterals to the RCA, which is the subtotal occluded. And also you can see the heavy calcification burden in the RCA. Sometimes you can say maybe there is a stent, but actually there is no stent. This is all heavily calcium. This is the view of the RCA, and as we can see, there is a high, there is like severe stenosis, almost subtotal occlusion, with kind of like TIMI2 flow in the distal RCA. So given that said, and given the patient has symptoms despite medical therapy, we decided to proceed to high-risk BCI of the RCA using OCT, keeping in mind that most likely patient will need some plaque modification with either ROTA, IVL, or orbital atherectomy. So we went through the femoral approach. We used 7 French guide, and we tried to pass the OCT catheter through that tight lesion, but unfortunately we could not pass the catheter. So we said, okay, we'll just pass a small balloon and try to make a tunnel for us just to get the OCT catheter. So we used 2.5 by 15 semi-compliant balloon at 14 atmosphere, and this was the next thing that we see after the ballooning. So as you can see here, there is very high-grade dissection with possible maybe hematoma. At that time, we didn't know what's going on. Is it really because of the balloon or the guide that just dissect the ostium of the RCA? Keep in mind that with heavy calcification, sometimes when you get the balloon out, it gets stuck in the calcium, and sometimes the guide can just go in and dissect the artery. So we thought maybe this is the case. So basically what to do next? I don't know whether Dr. Abdullah, we can pause here and ask the expert panelist how it can approach.
Yeah, but we need to make it very short. Anyone, please.
Take it on the stent and seal it.
Okay, so maybe stenting. So this is the first thing come to any operator mind, just like, the dissection happened now. It will be very easy to go and stent. And we said, okay, maybe before that we'll just do ballooning. Sometimes just angioplasty, it can stabilize the dissection. So this is what we did. We went with the balloon, and you can see in the first picture, the mid-RCA yielded. But we went to the proximal RCA, there was almost like a dog bone deformity. There was severe wasting of the balloon. We went up to, by 4 balloon, up to 22 atmosphere. And even with that high pressure, we could not yield the proximal, and the calcium will not give up. We thought at that stage maybe we'll just pass IVL balloon or cutting balloon just to make it yielded, but unfortunately at that stage we could not advance any catheters. Given that said, at that stage, the patient was hemodynamically stable. He was not having any chest pain. There was no ECG changes. We took just a small injection just to see the flow. There was good flow. The dissection was still there. So we said, you know what? We'll just leave the patient now alone. Let him heal the dissection. And maybe after a few weeks, just we'll think what to do next. And this is exactly what happened. So we make the patient to wait in CCU for 48 hours, observed he was totally stable, discharged, and brought back after a few months. And this is the next imaging. So we went again, femoral approach. And as we can see now, the dissection totally healed in the RCA. There's good flow. And we see that very high-grade stenosis in the proximal. So what we did this time, we went with the OCT, and the OCT catheter went well. And as we can see in the images here, that there is heavy burden of calcium. There's almost 360 arc of calcium. So no more ballooning now. We just went up front with a atherectomy to make the road babe for us to deliver an equipment. So we went with orbital atherectomy, using both at low speed 80 RPM and high speed up to 120 RPM. And after that, we went with regular balloon. And again, with that, there was still significant wasting, and the calcium will not give up. But at least now, things are much easier to deliver equipments because of the ablation. So we decided now to go with IVL and using 4 times 12 balloon, 120 pulse delivered. And now, as we can see, the lesion gave up and yielded very nicely. This is like an OCT showing very nice demonstration of fracture of the calcium. There's good fracture at 12 o'clock, 3 o'clock, and 6 o'clock. And this has made us happy now that, you can safely go and put a stent. So we put a stent, 4O times 34 in the mid and proximal, and showing a good result. The OCT was also done, which showed well above stent. There was no evidence dissection. So what is the learning point from this case? So always we need to respect calcium. Don't underestimate calcium. Maybe if you said sometimes, I'll use balloon or something, the lesion will yield, the calcium will lead, but not infrequent, you'll end up with dissection like in this case, and you'll not be able to do any atherectomy. So use atherectomy up front and not to go in the rota or orbital regret as in this case. Consider using IV imaging to guide intervention, especially in heavily calcified lesion. And the most important thing, dissection can heal. So dissection can heal, it just needs time. Thank you very much.
Excellent, Adil. I think this is a reminder.